Hey, welcome back. Welcome back to my channel. Today we're going to be talking about pulmonary pulmonary hypertension. Okay. So what is pulmonary hypertension? Let's first define it. It's basically when the mean pulmonary artery pressure exceeds 20 mmHg. That's when you call it pulmonary hypertension. Now the grades have sort of grouped classified pulmonary hypertension into groups 1 through 5 based on the etiology of the condition. So let's start by talking about those 5 groups and what the etiologies are in these 5 groups. So the first group, the group 1, is going to be either heritable, or it could be because of drugs and toxins. Now, heritable pulmonary artery hypertension is when there is a mutation in the BMPR2 gene. BMPR2, when it's properly functioning, it usually inhibits vascular smooth muscle proliferation. So when that's not happening properly, you're going to have intimal hyperplasia, medial hypertrophy, intimal fibrosis, and plexiform lesions, wherein basically if this is the cross section of the pulmonary artery the way it's supposed to look like, by the time all the pathology sets in, you're going to have multiple plexiform capillary lesions inside your pulmonary artery. Okay, it's pretty bad. And then drugs and toxins are going to be, this list is again not exhaustive, but there's cocaine, there's amphetamines, there's certain SSRIs that can cause pulmonary hypertension. There's certain chemotherapeutic agents like bleomycin and cyclophosphamide. Okay, now that's group 1, right? Now let's move on to group 2. Now group 2 is when pulmonary hypertension happens because of left heart disease. Okay, and this can be either systolic or diastolic dysfunction, right? Dysfunction, or valvular pathology in the left heart, right? Now let's go to group 3. You get the pathogenesis, right? Because your left heart is not pumping properly, there's going to be stagnation in the pulmonary vasculature, and that will cause the hypertension. Now, group 3 is going to be pulmonary hypertension because of lung disease, right? And there are so many, right? So this can be restrictive lung disease, it can be obstructive lung disease, it can be sleep disordered breathing like OSA, it can be chronic high altitude living, right? Like interstitial lung disease, COPD, OSA, chronic high altitude, and developmental lung diseases. The way that OSA causes pulmonary hypertension is basically you tend to have recurrent hypoxia and hypercapnia. The hypercapnia itself can cause vasoconstriction of the pulmonary vessels, and also it can cause hypoxic pulmonary vasoconstriction, which is a phenomenon wherein the pulmonary vessels clamp shut in certain areas to divert blood to better oxygenated lobes of the lungs, so that can happen. Chronic high altitudes also have a similar mechanism where they participate in hypoxic pulmonary vasoconstriction. Right now, group 4 is going to be what we call CTEPH, which is chronic thromboembolic pulmonary hypertension. Basically, there's going to be thromboemboli in the pulmonary vasculature, and that is the main cause of the hypertension. And group 5, this is an interesting group. Group 5 is going to be basically anything that is either multifactorial or when the mechanism is unclear. Now, some of these are going to be hemolytic, chronic hemolytic anemia, like chronic hemolysis. So what happens in this, because sometimes it's unclear, but the ones that I have figured out, I am going to explain to you. So what happens when you have hemolysis is that hemoglobin scavenges the nitric oxide, which is a potent vasodilator, right? And then you have decrease in nitric oxide, and that causes your pulmonary vasoconstriction. And one more thing is that in hemolytic anemia, there is an increase in endothelin, right, which is a potent vasoconstrictor, right, and that also contributes to the pulmonary hypertension. So that is your hemolytic anemia. Let me just change the color so that you all don't get confused, right? So this is hemolytic, right? And another one is chronic renal failure, especially if they're going dialysis. So what happens here is your just a sec. There is going to be a derangement in the calcium and phosphate metabolism, and that will cause calcification of the pulmonary vasculature, and that in turn can cause your pulmonary artery hypertension. Other etiologies that can fall under group 5 is a tumor that presses and causes pulmonary hypertension. It can be because of sarcoidosis and pulmonary Langerhans cell histiocytosis, and metabolic disorders like glycogen storage disorders, right? And in this, if you remember the glycogen storage disorders, some of them can cause glycogen accumulation in the heart, and then that would cause your left heart cardiomyopathy, right? And some of them can also present with lactic acidosis, and lactic acidosis itself can cause pulmonary vasoconstriction, and that's why this is multifactorial, and it comes under group 5. So these are the 5 groups, right? Now let's talk about the presentation. So the presentation. So how is pulmonary artery hypertension going to present? Obviously, it's going to cause right heart strain, right? First, we'll talk about the pathophys, and then so it causes right heart strain, right? Let's start from here. Now it's causing right heart strain, so you're not able to pump your blood into your pulmonary vasculature, and that would cause you to have exertional dyspnea, And because of the right heart strain, you're also going to have angina, right? And because your right heart is sort of congested, you can have ascites and pedal edema, right? And there is congestion of the blood in the pulmonary vasculature, so occasionally it can present with hemoptysis. Because your left heart is also not pumping properly, because it's not able to give out an adequate cardiac output, you can have exertional syncope, right? Another thing is that because there is low oxygen content in the blood, they can have cyanosis, like bluish lips because of low oxygen content in the blood. And because of the strain on the right heart, it can also present with arrhythmias, right? Now, on physical exam, again, these things are very logical, people. Like, because there is right heart, it can progress to right heart failure, and as such your right heart is not pumping well enough. There can be an elevated JVP, that is seen as jugular venous distension, right? And they can have, like, on auscultation, loud P2, which is the pulmonic component of the heart sounds, right? So the HS2, that is the heart sound 2, has an aortic and a pulmonic component, and because your pulmonary pressures are high, the pulmonic valve, when it closes, it causes a loud P2 sound. Okay, and then they can also have left parasternal lift due to right ventricular heave. Okay, right ventricular heave is, again, your right heart is trying to push against high pulmonary pressures, and that can cause it to have a heave, and that would be felt as a left parasternal lift. Okay, these are the things that you will see on physical exam. Now, how to go about diagnosing pulmonary hypertension? Now, your basic things, like when you do an ECG, you're going to see right axis deviation because of right ventricular hypertrophy, right? And on chest X-ray, you will see enlarged hyla because of the pulmonary artery enlargement, right? And when you do a PFT, you're going to see a restrictive picture. Now, the main ways is, like I said, the mean pulmonary artery pressure is more than 20. So when you do an echo, that can give you a pulmonary artery pressure. This is non-invasive. So the pulmonary artery pressure will be high, and in some cases you will be able to see some degree of tricuspid regurgitation, because obviously, right, your right heart is not able to pump into the pulmonary artery, so it will regurgitate a little bit back into the tricuspid valve, through the tricuspid valve. So you'll see increased pulmonary artery pressure, you'll see tricuspid regurgitation. And now the invasive way to get the pulmonary artery pressure would be right heart catheterization, and that will give you a direct measure of pulmonary artery pressure. Okay, now so basically that is the overall how you diagnose both clinically and with investigations the pulmonary hypertension. Now let's talk about management. Okay, so there are several drugs. So the first one I'm going to talk about is bosentan. This is an endothelin receptor antagonist. Okay, now I told you before endothelin causes vasoconstriction, so if you block that, you're going to cause vasodilation, and that will be your bosentan. Okay, the next drug I want to talk about is PD, phosphodiesterase 5 inhibitors like sildenafil. Do you remember where we saw this? We saw this in erectile dysfunction, right? So what PDE5 does is that it breaks down cyclic GMP, which is a vasodilator. Now when you block this, you have increased cyclic GMP, and that will cause vasodilation again and relieve the pressure on your pulmonary vasculature. The next one that I want to talk about is riociguat, which is a stimulator of soluble guanylate cyclase, which generates cyclic GMP. Okay, again that's a vasodilator. We also have prostacyclin analogs, right? Those are going to be iloprost and epoprostenol. Prostacyclin is PGI2, which also is a vasodilator, so we can use this. These are again all the medication options, right? Because I myself have not managed cases of pulmonary hypertension, so I cannot give you properly like the regimens and the dosages and the combinations that can be used, but I can definitely make a separate video on managing pulmonary hypertension. This was more focused upon giving you an overview of pulmonary hypertension, and the other things that you do want to do is light aerobic supervised aerobic exercise for to increase exercise tolerance, and they can be given supplemental oxygen because like I told you, they are going to be cyanotic and hypoxemic, so supplemental oxygen can be given. And also you can give them diuretics because you might know that the right ventricle is very sensitive to volume changes, right? So giving diuretics and getting rid of that extra volume can sort of decrease a little bit of the strain on the right heart. Okay, so these are the ways in which you can manage pulmonary hypertension. I hope that this was a good video for you all. Sorry about that. We did the classification of the groups and how sort of the pathogenesis of how they cause pulmonary hypertension. We did the clinical presentation and the physical exam findings. We did the investigations that you can do to diagnose pulmonary hypertension, and I gave you a little overview of the treatment of pulmonary hypertension. So I hope you found this video helpful. I hope that you will go ahead and read up on this to sort of familiarize yourself a little bit more. Rewatch this video as many times as you need to sort of drill these concepts into your brain. I hope that this was a helpful video. In the comment section, let me know if there are other topics that you'd like me to sort of touch up on. Thank you so much for listening. I will see you next time. Bye bye.